I would like to call upon our next speaker, Dr. Chirojit Mukherjee. Okay, he is the chairman of anesthesiology and critical care medicine at Karlsruhe, Germany. Dr. Chirojit has been associated with IACTA for more than a decade now, and with all the academic activities of the IACTA, he has been at the forefront. He has numerous publications to his credit and is involved with various guideline committees and trials of the recent technological advances in the field of cardiology, cardiac surgery, as well as echocardiography. So today, Dr. Chirojit Mukherjee would be speaking on echocardiographic perspectives in beating heart mitral valve surgery. Over to you, Dr. Chirojit.
Thanks, Nilesh. I hope you can see my picture. Okay. So, thank you for the invitation. Thanks to Dr. Muralidhar and his team. Thanks to IACTA, and it's a very good sunny day in Heidelberg, Germany today. And I'm going to speak on beating heart mitral valve interventions. And I can only reiterate that fact. All of you are welcome on behalf of IACTA also. Being the Secretary General, I invite you all to Leipzig next year and visit an online event of IACTA Echo course next year. I am shutting my video down because I believe Dr. Dasurkar has sent a message that there are almost 200 participants and it's slowing the video speed. So I'm going to talk without you seeing me, which most of you have seen me. So I don't think it adds to any value of this lecture. So I have no conflict of interest, and today you're going to learn, or I may try to make you learn about what are the percutaneous procedures available, what are the challenges you face during the transcatheter mitral valve therapies, what is the the available technology right now for repairs, and ultimately we are going to start on what is known as a transcatheter mitral valve replacement, which is the new kid on the block, and I'm going to give you a brief insight on that. As you know, it's not a rocket science. The older you grow, the chances of getting a mitral regurgitation gets higher. So it's almost threefold after the age of 65. And the impact on survival is more on the expected than on the observed. So the observed ones are actually time since diagnosis within a rapid span of 6 to 10 years. The observed value of mitral of survival gets much lesser than the expected value. So this has to be treated as at the foremost when you see a diagnosis of mitral regurgitation. And like any other structural valve disease, a good ejection fraction gives you a better survival compared to a poor ejection fraction. And this was published very well in Lancet by Diazko and his group. And they showed that patients with ejection fraction more than 50% did much better than patients with ejection fraction less than 50%. So you see, many of the people had actually been refused surgery. So there is increase not only in the mortality, morbidity, but also on the hospitalization. So they are frequently hospitalized because of the incidence of MR. And only half of the people actually underwent surgery. The rest were denied surgery. And goal-directed medical therapy, actually without any intervention, was almost more than 60% of the patients. And more than patients were actually who are more than 70 years or more than 2 comorbidities were denied surgery. So you can see there is an unmet need. And so you need to venture on the alternative therapeutic options right now, which is available in the market. So if you go by the Carpentier Classification, most of you, I'm not going to the details of that, but what I'm going to say is that all the therapeutic intervention on beating heart interventions are based on basically on secondary MR, basically on non-ischemic cardiomyopathy or cardiomyopathy, or basically type 1 and 3B. That's the one which the beating heart mitral valve interventions are required or cater to. So guidelines for management of MR, the recent guidelines from AHA, ACC, they said that if you are going by the transcatheter treatment, they're either edge-to-edge or they're enrolling trials. And that's what I'm going to talk to you about. What are the trials and what are the forthcoming trials and what are the forthcoming therapies which are available right now. So basically, it can be divided into 3. That's one is the cooptation devices. Second comes the annuloplasty devices. And lastly, which is new, I said, is the transcatheter mitral valve replacement. So if you go by this, either you look this part where you're trying to shorten the length of the annular distance, that's by an annuloplasty device or the cooptation device. then you cater to the secondary cords, and ultimately, if none of these function, then you go for a valve replacement. So I'm going to go into details of these three interventional options. So let's start with the coaptation or edge-to-edge mitral repair. So either you do a mitral clip procedure or you do what is known as the Pascal system, which is right now new in the market. I know many patients have undergone this in Leipzig Heart Center. And if you have any specific questions on this, I have very little expertise on this. Dr. Ender or Professor Ender would be able to give you a better insight onto the Pascal system. Percutaneous transcatheter edge-to-edge repair is what is known as the typical Alfieri repair. So Professor Alfieri, basically he took the A2 and P2 and sutured them together, giving to typically the figure of 8 picture, or known as the Alfieri repair. So surgically, Alfieri repair is very similar to your mitral clip intervention, but there are some basic differences between mitral clip therapy and Alfieri stitch. And it is a single or a double stitch where you can, fusion of the A2 and P2, but here you may need up to 1 to 3 mitral clips during the procedure. They are based basically on the MR jet, but here your orientation is based on not only the jet, but also on the direction as well as the response to therapy. So after you have clipped one clip, then you have the option to go back and put a second and if not a third. But these things are changes where electively many people are putting in 2 clips at the same time and not relying only on 1 clip. So the patients have often, they had risk for open heart surgery. So all these people who could not undergo surgical surgery or were not ideal surgical candidates undergo the mitral clip therapy. And the image guidance is mostly with TE as well as fusion imaging, which I'm going to show you in my later slides. And you can assess hemodynamically on a beating heart mitral valve intervention. And for optimal quantification, you can actually assess intraoperatively in both the cases, the quantification of MR grade. Mitral clip, as you know, has undergone a new reiteration where the 3rd generation system or so-called the NTR or XTR has come. So you have a much broader XTR system where the grasping area has really increased. The grasping width is almost like more than 5 millimeters. The clip length here you can see has also increased. So you add additionally 3 millimeters. So if you are going in for 2 clips selectively with a normal mitral clip previously, now in most of the cases, you can actually do it with the XTR in those cases. And what's the biggest advantage is you have more coaptation surface area compared to a single clip intervention or the original mitral clip, which was devised. So with this kind of a new, development of the mitral clip, you have extended indications, obviously. So you have not only the prolapse of A2P2, so that extended to A3P3 as well as A1P1. So if you go from here, you have actually gone up, the indications have increased. So annular calcification previously was a no-go, but now leaflet calcification, annular calcification, post-surgically, which has been failed, annuloplasty repair, SAMP. Some few cases have undergone also mitral clip by SAMP procedure who has actually shown SAMP post-intervention. And obviously, these are the ones which are very difficult to treat, are valve clefts, and as well as severe functional MR. And with the European experience, following the CE mark, the 3rd generation system has shown that the steering performance was compared to the native mitral clip was much better, as well as you have the grasping or capture performance almost 100% better, and the MR grade regurgitation has come down drastically. And also, which is possible if you are going for a mitral clip procedure with the model-based interventional guidance, you can actually mimic the surgery or the outcome of the surgery preoperatively using what is known as the Siemens system, where you can actually, using a fusion imaging with the fluoroscopy as well as model-based guidance, you can mimic the whole surgical procedure even before you start the procedure. So going into the Pascal system, the biggest advantage is you can, in my opinion, one of the biggest advantages, this spacer which you have is designed to reduce the whole effective regurgitant orifice area. So you have a much more grasping area. And if required, which I think initially I thought is a big advantage, but right now I think it's not that much of a major advantage, is the independent leaflet capture, where you have a flayed leaflet of P2 and you can independently capture it. But ultimately, if you see the spacer can actually co-opt with both the leaflets in place. And the initial results from Pascal system, you can see here, so MR grade 0 to 1 was drastically reduced from grade 4. So basically, typically the people land up between anything between 1 and 2 plus. So this is a good system, and it needs probably 2 cohorts to see which is better. And this, I'm sure that there's somewhere the studies are going on. If not Leipzig, I won't be surprised if they're comparing Pascal and Alfieri technique or the mitral clip system to see where the outcome or what is the future generation devices are going to look like. So coming to the second part of my talk is the annuloplasty devices, where you have mostly the cardioband, where you have a transseptal or transvenosus, where you can go through the groin and ultimately you form a band around the dilated annulus. So these are basically for dilated cardiomyopathies where the annular distance has more than 40 millimeters, as severely elongated. So basically you grasp and go technique where you implant, then you anchor, basically you just screw mechanism. So you just screw it in on the annulus and tissue and just proceed further. So you have the implantation catheter, which can be adjusted after the implantation, and they are basically grasp technique after by fixing the metal anchors, which you can see on this. And ultimately, if you can see, this is a case which was showing a grade 3 to 4 regurgitation, and basically 3 regurgitation, and after the whole final adjustment, you can see that the regurgitation life has been drastically reduced. So initially, the procedure in experienced hands can take anything between 4 to 6 hours. So, but now with expertise, you can boil down on a good day between anything between 1 to 2 hours. So cardioband is definitely in the progress, and the largest, to my knowledge, is the largest group is the Maizano group from Zurich, who has done a lot of these cases. But unfortunately, with their own paper, they have shown that although the life quality, the Minnesota life scoring has improved, but at the discharge, when you see you have an MR of 0 to 1, but with a 6 months follow-up, the group has from Nickening et al., they could show that the MR grade 2 was more than in that 45% of the patients. So there is an ongoing, even after you implant the cardioband, there's ongoing dilatation of the ventricle, which may be detrimental to the outcome of the whole procedure. So these are the things which you have to keep in mind as a long-term outcome. These interventions are not yet scientifically, you cannot say there are truly established procedures. These are all on clinical trials, but there is a promising future to these interventions. Like I said, with this, all these things coming into the market where you try to reduce the annuloplasty device or annuloplasty distance, with the ring, there's the Valcare procedure, you have the millipede. So all these things are coming up into the market. And the whole idea is to reduce this distance between the green to the green point and increase the coaptation length between the two by reducing this distance. That's the whole idea of all these annuloplasty devices. So next, or in the last part of my talk, is the transcatheter mitral valve replacement. So where this is basically the big next, or the big thing you can say, which is going to come up in a big way in the next probably 2 to 3 years. There are some challenges, and I really like to, don't want to discourage anyone, but it's not easy as, or rather I won't say easy, but it's not as easy, or I won't say, rather I would say the challenges are more in transcatheter mitral valve than compared to the transcatheter aortic valve replacement, because although the axis looks direct axis, but there are challenges. That first is the positioning, where you go 50-50 or you go 75-25 into the atrium, into the ventricle. The sealing of the valve can be really challenging, so the chances of migration are very high. And because of the proximity, and they're very close to the left ventricular outflow tract, what it can cause, and that is my biggest nightmare, where after implanting the valve, you have LVOT obstruction. So it can be because of the anterior movement of this mitral leaflet, it can actually block the LVOT of the, and being in close proximity to the aortic valve. And these are the things which I can't really answer now because these are all on clinical trials. How the valve is going to be thrombogenous or not, what's the long-term durability, and obviously the prosthesis anchoring, which is going to happen, whether you can be sure of not doing with the paravalvular leak and the challenges of anchoring into the mitral position. So these are the initial cases which was done way back in 2011, 12, and I think the first case was in 2010 in Leipzig, and this is one of my previous slides. And this is after I joined in Karlsruhe, I started this procedure along with our cardiologist, where there are a couple of these we have done with very good results. Actually, this is one of the easier procedures where a valve is in place and you go transapically and implant a transcatheter or transapical mitral valve, which on a previously implanted valve. So these are very straight cut procedures compared to a valve in ring. A valve in ring on a previous valve, which can be very challenging, where this is a patient who has undergone 3 surgical repairs and come with a aortic stenosis as well as a mitral regurgitation. So this is during my time in Leipzig, where we did a ring of new valve implantation in the ring, where you can see, as well as a transcatheter aortic valve replacement, and the patient did pretty well. Obviously, the ejection fraction was less than 30%, and although because of this procedure, they could go home without any complications. So this is more or less like a bailout procedure. And we published our initial findings, and we could see there was a good increase as well in the, not only on the ejection fraction, as well as the opening valve area in the small 20 patients database, which we did using percutaneous transapical mitral valve replacement. So as you can see, this is actually right now probably $15 to $20 billion project going on all over the world, where all they have there is they're not only in the clinical program, they're first in human trials, and you can see these are the new kids on the block, and they're all coming up or trying to come up in a big way in the development of transcatheter mitral valve procedures. There are 2 valves which we have personal experience, and I like to show is, one is the Abbott 10-9, where it is a self-expandable nitinol double frame valve. So it's like a parachute opening where you have an inner frame, which is circular, and an outer stent, which you can see. And it goes obviously transapical, and it's a fully recapturable system. So if you have implanted higher or lower, you have the tendency, you can retract and recapture the system after the valve has been deployed. And ultimately you can put it as the unfortunate part of it is only comes in a single size. So we don't have multiple size, although the outer frames have multiple sizes. So you can go, but what really helps if you have a 3D echo is a double view where you can go from the atrial side as well as the ventricular side. So this is one of the newer valves, which is the Abbott 10-9 used for transcatheter mitral valve replacement. One other valve is the Intrepid from Medtronic, where you can also, it is self-expandable, but it is not fully recapturable, and it is intraannular, so also transapical positioning. And the advantage is it's a dual stent design, so you have an outer frame and comes in 3 sizes, 3 outer stent sizes. So depending on your annular size, you can have either a 43, 46, and a 50 millimeter outer stent sizes. So that's a big advantage compared to the other valve. And the initial results are, I won't say very promising, because you have a mortality, all-cause mortality ranging from 3.3 to 53%. So that's a huge number. 53% mortality is very high. But what you can see, the New York classification or functional class is very promising. And the overall mortality over a follow-up in months is not that grave initially compared to the 30-day mortality. So it's definitely on the clinical trials. I'm going to show you're going to see more of this in near future. And lastly, surgically, what can be done is the transapical beating heart mitral valve repair. So it's a catch and grasp technique. So you go transapically. And what you can do is basically, once you see a leaflet being prolapsed, you just grasp on it, and you have what is called a leaflet capture display. So the moment it grabs, the color changes from red to green, and then you tie and knot, you try to pull it up and fix it down. So basically it's like a surgical repair using Gore-Tex suture, but you have to do this on a beating heart, which is very challenging. So neocords can be very challenging for a surgeon as well as the anesthetist, because that's the only guidance which a surgeon gets is your live 3D echo. And I can certainly say the orientation needs to be, you have to be very well oriented to do these kind of procedures. And once you have grasped it, you can pull it down. And once you have put in a kind of a knot technique or the loop technique, you can pull it up and grasp and then repair the whole of the leaflet. So this is a new procedure, which has been, well, relatively new, almost 6 years in the market now. And the orientation is that typically you have to have a medial, lateral, posterior, anterior. But what is also very important is if you can really see this procedure live, and if you can guide by a biplanar procedure, and if you can see this, if you're on a 3D echo, you can see if the knot is too loose, you see there's a lot of gap between the loop height, and you can change this. If it's too loose, you can actually tighten it, and there you can see it's almost like a really tight situation. You have to find the real ideal situation, and that you can do in collaboration and coordinating with your surgeon who's doing the procedure or the cardiologist who is doing the procedure. So what is next going to come? And I'm really excited because we are getting this next week to our new hybrid OR, and we have this model-based interventional guidance where you do the fluoroscopy and 3D echo, as well as the biplanar fusion. And you can actually do all these live procedures using a live fluoroscopy as well as your 3D superimposition of your real-time 3D TE. So hopefully I can keep you in the loop and see how advantageous it is for an echocardiographer as well as a cardiac interventionalist. So to summarize, I would like to say that there is a high prevalence which is coming up of mitral valve disease in the aging population. Right now, we know that E2E or the edge-to-edge repair is the most studied approach, whether be it Alfieri technique in surgically or whether be it mitral clip. So novel, all these new direct annuloplasty devices, it's not yet established, but it's definitely showing some future promise. And ultimate future, which is still a big mystery, is the road ahead using the transcatheter mitral valve replacement, but it is obviously going to be more challenging because of the reasons mentioned earlier compared to that of a TAVR. And I am sure that, with all this multimodality imagings, we are going to play a very, very significant role during the implantation of these valves. And I'm really excited that this is going to be a future generation of intervention, which we are going to see in the next 4 to 5 years. And hopefully we will all be in the position with or without Corona, and with this kind of virtual reality techniques, we can actually be in touch using the net. So that's hopefully we have keep on exchanging our knowledge through these kind of lovely virtual meetings organized. So thank you, Bangalore. Thank you, Narayana. And sign off from Heidelberg. Thank you to Nilesh and the moderators.